part where it's not as successful, most people go back into atrial flutter. They don't stay out of it, so a lot of times they end up with evolutions or sometimes pacemakers. Yeah. So basically, once again, same as atrial fibrillation. Anticoagulate, rate control, rhythm control. Same drugs are used. This is the slide that has all of the links on it. That very top link is the one that is the big guideline paper. That may be easier for you to learn from than it was for me. That is all mostly in list form as far as the treatments, and it gives information on where they came up with the treatments and all that, which you don't have to know. They do have good charts and things in there. The other ones are some of just the videos that were at the beginning. The second video, I think, is actually more here. So, the rundown. This is for atrial fibrillation and flutter. Those are the main symptoms. Palpitations, dizziness, fatigue is the big one. Sometimes shortness of breath. They'll just feel like they're winded when they're walking. The workup that you do, and then treatment, rate control, rhythm, prevent clots. Yeah, definitely remember those three things because you have to try to address all of them. And then the cardioversion. So this is an example, 76-year-old female, history of hypertension. She takes medicine for that every day. Started with atrial fibrillation today. Complaining of feeling tired, a little bit of short breath, no previous history of AFib. Non-compliant with her blood pressure medication. Pulse, her usual pulse is 84 when she's not in atrial fibrillation. So what do you think first line treatment would be? Keep in mind, under 48 hours, you know what started today. She can immediately be cardioverted, so you can send her to the hospital and then cardiovert. You can also, and they would start anticoagulation therapy at the same time, but she doesn't have to wait. And then what is her CHAD score? If it's over 3, what do you do? There you go. So she's over 3 because she has hypertension. She's over 75. And female. Okay, any idea on medication you might start for rate or rhythm control? She's already on lisinopril, which is an ACE inhibitor, which isn't going to be doing much for either one of those. So you could switch her, and this is just basically on your opinion, because you could do rate or rhythm control with her. But rate control is generally easier, and the medicines have less side effects or risk of going into abnormal rhythm. So you could just switch her over to a beta blocker to help with rate control. Now, the other thing is anticoagulation. What would you try to anticoagulate her with? This is just so you have to keep in mind, you have to think about your patient. So if she's non-compliant, which is why this is in here, if she's non-compliant with her blood pressure medicine, do you think she's going to be compliant with going to the doctor once a week? Probably not. She may do better on one of the direct, exit inhibitors and thrombin inhibitors, as opposed to warfarin where you have to go in all the time. But then again, you have to take into account cost and does your insurance pay for it. So you spend a lot of time making a plan with these people that they can follow. Personally, if I had to go to the doctor once a week and have my blood drawn, I wouldn't be taking the medicine because I'm not going. So I'm a bad patient person. So that makes a difference. Okay, so here's a 48-year-old. Hasn't been to the doctor in forever. Has high blood pressure, his pulse is 122, he's setting fairly well, weight 308. And you listen to him and he's in AFib. He's never had this before, so what test are you gonna do first? Hmm? Hey, yes. So most offices have those, or you can send them to have one. Treatment options for him, he is, once again, you're gonna have to do some labs. If he weighs 308 pounds, hasn't been to the doctor in 10 years, don't worry about him being diabetic. He could be hypothyroid, so you need to do some of those tests first before just plopping him on some medication. And then he would be a candidate for immediate cardioversion, or close to near cardioversion if you know how long the episode's been going on. If it's over 48 hours, then they'll anticoagulate first. You can anticoagulate if they're stable as an outpatient. You can anticoagulate them for 3 weeks and then cardiovert them and then leave them on maintenance medicine after that. And that's the end of it. Those were lumped together. So do you guys have any of your slides that'll come up?
Yeah, we have it on now.
Oh, okay, good.
You see at the bottom, it looks like a little trophy next to the thing, like down a little bit. There, click that.
So you can't find the button. So this will be much easier than the last one. So you guys are getting tons of information today. So first of all, do you guys know what supraventricular tachycardia means? I'm going to take that as an So just remember, supra means above, so it's a tachycardia that's coming from above the ventricles, so it's basically coming out of the atria. But it is not irregular like atrial fibrillation, it's just fast. So where atrial fibrillation was irregular, SVT is regular. So you're getting regular beats at regular intervals, it's just going really fast. Generally it's 160 to 200 beats a minute. Sometimes it'll be less than that, and patients will be symptomatic, even at the like 120. Once again, this is caused by accessory pathways, usually in the atria. So just like atrial fibrillation normally will come out of the left atria, this one usually is in the right, and it just takes over, it bypasses the AV node into the ventricles. So you get a very fast rhythm. And once again, what happens if your heart is beating 200 times a minute, even if it's regular? Probably not squeezing much blood out of that, so you're not perfusing very well. So some of the symptoms of this and symptoms of atrial fibrillation are very similar. Dizziness, palpitations, you get very lightheaded, so like standing up you'll get swimmy. You can have chest pain. Most people will feel this one. They'll feel like their heart's beating out of their chest. And shortness of breath because you're not perfusing to the lungs either. Physical exam, once again, this one's pretty easy. It's fast and regular. And usually you'll do an EKG if it's, people with fevers will have a heart rate of 110 to 120. But this will be usually beyond that. And then the delta wave, that is basically this, what they consider here, where you get this pre-excitation. So one of the treatments for this, so do you guys know anything about the vagal nerve? Okay, so if you stimulate that, what happens? And your heart rate. So this is one of the first treatments. So if you can do this in the office. Somebody comes in and they're tacking along at 170, you can basically make them bear down like they're trying to poop, because that will stimulate the vagal nerve and sometimes drop them back into a normal rate. Now you have to be careful though and watch their blood pressure, because it's going to bottom that out too. So if their blood pressure is already low, you better be prepared for them to fall out. You can stick their face in some ice water, rub the carotid areas here, and then of course have them strain. If that doesn't work, or it works for a little while and it comes back, you can have them do it again. If it works, then you can just get them basically a cardiac. So if they are, once again, unstable, if they are having a hypotension, they can't talk to you, they're confused because they're not perfusing, you can have them try vagal maneuvers if they're coherent enough to follow your directions. If not, you're going to do a synchronized cardioversion just like you would with AFib. And then adenosine is one of the cardiac drugs that'll be in your wonderful ACLS. And I put a link in there to the ACLS algorithms guidelines. They're getting ready to update those again, and I hate to be the bearer of bad news, but they're going to take atropine out, except for Brady. It won't be in for doing like CPR anymore. Stable, if they're stable, you do the vagal maneuvers. You can give them adenosine if that doesn't work. Beta blockers as first-line treatment. So if you can get them to stimulate their vagal nerve in the clinic and they go back into, normal sinus rhythm, then you can start them on a beta blocker unless they have some kind of contraindication to that, or a calcium channel blocker. They do, and I'm not going to do this where I work, but some of the big cardiology clinics actually will give them Sotalol IV in the clinic. You better be prepared for the better have an ACLS card there, just in case with that particular treatment. That's usually something they would do in the ER. Wolff-Parkinson-White is part of SVT. That one, they get the delta waves with that, a lot of pre-excitation. This is usually in young people, and their first episode, usually they will have a complete syncopal episode where they just pass out for just random reason. And then they'll find that they have this. Most of the time they do electrophysiology studies with this and then do a catheter ablation because it's recurrent, and this particular version is harder to treat because of the pre-excitation. The meds don't work as well, and there's more risk to going into abnormal rhythm. So just remember, you're probably going to get zapped if you have WPW. And they will go on to have atrial fibrillation at some point for 30%. There's the little delta wave. I don't know if you guys can see that on your screen. Basically, it's just widening out, and there's not a lot of separation between the P and the QS. Okay, so basically, now you might be the specialist, just keep that in mind looking here. For me, they would go to the specialist. So if they have signs of WPW, you're going to send them to the cardiologist. Now you might be the cardiology PA doing this. So, and then people with recurrent symptoms, if you've had them on like 3 or 4 different meds and they're not staying, they keep having breakthrough SVT, probably send them to the cardiologist. Some of them will end up with ablations even if they don't have Parkinson's. If they've had a syncopal episode, and they have the pre-excitation on EKG and they won't convert, they're gonna go to the hospital. This is a little picture of how the pre-excitation goes through the little pathway. There are other versions of this that you can find. And that's the end of it. Nice and short. Do you guys have any questions about AFib or SVT so far? Are you guys awake? I told you the other one's a beat faster. Let's see. Okay, so we just did supraventricular tachycardia. So this one is actually the ventricular tachycardia. Much worse than the SVT. So for this one to actually be considered ventricular tachycardia, so on your EKG, instead of having a whole bunch of QRS, this is what you get. They're kind of wide looking, they can be narrow like the one at the top, but it's so fast that nothing else shows up except for the abnormal QRS. You won't see a P wave or T wave or anything else. So you need 3 or more consecutive beats to consider it ventricular tachycardia. Every once in a while, somebody may have 1 or 2 of them that occur, but if it's sustained, and it'll be over 100 beats a minute. So there's sustained and non-sustained. If it's more than 30 seconds, it's sustained. Symptoms. Once again, you're not pumping very well, so syncope, lightheadedness, dizziness, palpitations. Any of the ones that are tachyarrhythmias are generally having the same symptoms. These ones people will usually have chest pain. These are the risk factors, so coronary artery disease, prior MI, any kind of valve disease, any kind of structural abnormality. So people that were born with congenital heart defects may be more at risk for this. You can actually have, once again, so this is why I started with the terrible atrial fibrillation lecture. The antiarrhythmic medicines you can see is listed as other causes of VTAC. That's what I was talking about. Some of those antiarrhythmic medicines that you might use in the people with atrial fibrillation, they may send them into VTAC. Or unfortunately, even VFib, which is not good. So you have to be careful about the medications. So if they're on an antiarrhythmic medicine and they go into VTAC, that might be one you might want to think about taking them off of. Electrolyte abnormalities. So if they have a lot of throwing up, diarrhea, and their potassium and magnesium and sodium get out of whack, they can go into abnormal rhythms just from that. Lack of oxygen. Drowning patients will often go into VTAC or VFib. Oh look, and I spelled failure wrong. Yay! It's a heart failure. Okay, so physical exam, once again, so if you're feeling somebody's pulse and it's 130 beats a minute, are you going to be able to tell by feeling their pulse that it's VTAC or SVT? Atrial fibrillation you could because it's so irregular, but these two are regular. So this is where the EKG comes in handy to differentiate where the source of the tachiness is. Sometimes this will be so fast you cannot feel a pulse. There's just nothing getting there. And once again, they may end up with an echocardiogram to check their blood flow, especially if they're really tachy. So if they're upwards of 200 here, their blood's not going anywhere, it's clotting in there. And the electrophysiology studies, again, are where is the source? Why is it doing that? If they can't get it to go back, they may do that to see, what kind of treatment may be effective. And sometimes even an MRI, just to see if there's damage to any of the actual heart tissue. There's the lovely pictures again. So you can see most people are not walking around with this. They feel really bad if this is going on. Although I will tell you, one of the atrial fibrillation patients that just came in recently to the clinic goes back and forth between AFib and VTach and can't tell the difference. So this is a big, lovely, messy slide. So if it's sustained VTach, if, you know, it's emergent, once again, if they are not perfusing, if they're having signs of shock, any of that, all of this is the same. You get them to the ER and they will cardiovert them. And I mean, if they're really out of it, you're doing CPR if you can't feel a pulse because the rate's so fast. Urgently, so if they're having it and they're pretty symptomatic, you still want to get them to, like, so if you're working in the ER, you're going to do an EKG and you're going to give them IV fluids and you're going to see if there's anything that you can reverse. So you'll do labs to check for like sodium imbalance or electrolyte imbalance. Sometimes they'll do the infusions, like the Sotalol again is a treatment for this, which they would do in the ER. Some of the medicines are different if they have left ventricular dysfunction. So if they have a low cardiac output, they're just not going to be perfusing well anywhere. So some of the drugs are contraindicated for that. Like amiodarone, which is the most common drug given, you don't really want to give that if they're having left ventricular dysfunction. It could actually send them into the So all of this is generally the same as the atrial fibrillation. You're going to do the same kind of class, you're going to do an EKG, you may do an electrophysiology study. So if they're not too terribly symptomatic and you're going to treat them as an outpatient, you're going to start with all of those things, their history. Do they have any history of heart disease? Are there things that you can correct, such as thyroid disease and things like that? And that's the end of that. I told you all these ones are short and sweet. You guys have any questions about that?
Does the PSVT, like if somebody has that, does that kind of by extension give them this? Since
They can go into this from that, but no.
so like what would be an instance where you could have the PSVT but not ventricular tachycardia?
The PSVT, that's supraventricular, so it's coming from the atria.
But wouldn't it still cause the ventricles to go fast?
Yes, but it's not the source of it. It looks different on the EKG as well.
So the source of this then is like
It's
the ventricles themselves?
Mm-hmm. Okay, these are the fun ones. So you guys will get to do these in the EKG class you have coming up. These are the atrioventricular blocks where basically there's a block in the electrical activity between the atria and the ventricles. So you get all kinds of weird things that happen with these. There's 3 types: first degree, second degree, which has 2 types of its own, and then third degree. The first degree one is pretty simple. Most people are actually asymptomatic with that one. They have a long PR interval, so since you guys haven't had EKG yet. So here's your P. So instead of your QRS being right here, it's like over here every time. So it's widened right here. And then second degree is a little more, there's 2 of those. Those ones are, this one doesn't ever block the QRS, so you have QRS with every P with this one. And second degree, you don't. First degree blocks, medications can cause this. Calcium channel blockers, so some of your hypertension meds can make it happen. And beta blockers. Beta blockers are probably the biggest offender of this. And it can go away, like if you're having ischemia to the heart, inflammatory disease, Lyme's disease, which is in Oklahoma, can cause this to occur. So, and age, if you think of it this way, so the heart gets stiffer over time, and you can get fibrosis and calcifications and things into the actual heart tissue. Or if they've had an MRI, it just may be a little bit delayed. That picture didn't come out well, which is why I drew that one. Second degree, they're called Mobitz 1 and 2. Mobitz 1 is usually known as Winky Buck. So this one, it gets longer and longer. So you may start off with a little P here and pretty normal. And then the next one, you get your P, and it's a little bit longer. And then it's a little bit longer, and then you lose a beat. So you'll have a P floating out by itself. You won't have a Q or S after it. So it just gets longer and longer and longer and drops a beat. Usually they're all from AV node conduction disorders. The reasons for this one are the same as for type 1. This is what it looks like. You can see the P wave. This is a little bit better picture than the last one. You can see the P wave's pretty normal on the first beat, wider on the second one, even wider on the third one, wider again, and then you lose one of the Q or S's. Mobitz type 2, there's no lengthening of the AV conduction. You just intermittently get no beat. And this one's usually progressive, so type 2, Mobitz 2, and type 3 are usually always treated. The other ones sometimes are just left to be as long as they're perfusion. This is a picture of it. So pretty normal. You have your P and then your Q or S, and they're even, and then just all of a sudden you don't get a Q wave. But the P's don't move over. It's just like you lost a Q or S somewhere. Third degree heart block. So this is the worst one, always treatable. Usually the QRS looks wide or it doesn't look normal. And what is happening is you're getting regular P waves and regular QRS, but they're not in conjunction with each other. The upper part of the heart and the lower part are doing their own thing separately. So if you count out the P waves or measure them and count out the QRS, both of them are coming equally. They are just not together. You won't always have a P wave where it's supposed to be from the QRS. These ones, they usually are symptomatic, and it's usually, they have a very low heart rate, so usually under 45. And this is what it looks like. So if you look at the little P waves, you see them coming at regular intervals. And this one gets mixed up with the second degree Mobitz 2 a lot because it looks like you might have a dropped beat. But in the second QRS wave, if you see there's a little hump in the bottom of that one, that's actually a P wave that showed up in the bottom of the QRS. And most of the, like type 1 and most of the type 2 Mobitz 1 are usually found incidentally. Those people may not have any symptoms. The other ones will generally have symptoms because the rate is slow and they'll get like lightheaded or they'll get short of breath or winded because their heart rate is not keeping up with their physical activity. They're usually found on it. So type 2 and complete heart block, those ones, they're going to end up with a pacemaker. Pacemakers are very effective in this. Like the arrhythmias, if you put a pacemaker in, well, their heart rate can still go above the pacemaker rate and they can still be tachycardic. That doesn't happen with the bradyarrhythmias because it's slowly getting up. And most of them, like type 1 and type 2 Moffitt's 1, really don't need treatment unless they become symptomatic. That one, you'll learn more about those in EKG on how that comes together, but they're pretty distinctive. You guys have any questions about that? Okay, so since you guys have had physiology already, right? So you know what the bundle branch is?
Yes.
Okay. So bundle branch block is a complete or partial interruption of that mechanism in the heart. So if it's blocked, then of course the muscle doesn't work right, it doesn't pump right, it doesn't perfuse right. It also depends on which part of the bundles are being blocked, on what symptoms they have, what it looks like on EKG. You know, sometimes you can't determine if they've had a myocardial infarction, depending on if they have a bundle branch block, because it'll hide in there and you can't tell the difference. So these are pretty simple. Right is blocking the right one, left is blocking the left one, and then there's combinations where you can get partial blockages in each one, and they can go back and forth where it'll be blocked part of the time and not part of the other time. So it varies on what it looks like. They usually have very wide appearance on an EKG. So this is a picture of the bundle branch and where the blocks and things occur. So, and any of the internodal pathways at the bottom can cause a block in appearance on EKG. This can be normal. This can be just how your fibers grew. It may have nothing to do with heart disease at all. Most of the time, however, it's from heart disease. So if you have ischemic heart disease and you don't get enough blood flow to the tissue all the time, well, it starts changing how everything works in there. Inflammatory diseases of the heart, so if you have, like even pericarditis can cause this, which is just the sac around the heart, but it works how it works. Cardiomyopathy, lung disease because it backflows more into the heart. So, and if you have people that have like Sjogren's disease and things like that, where it causes changes to the soft tissues, that can affect the heart as well. So if you can find a reason that they have it, you want to correct that first. So if they have some kind of pulmonary disease, you want to get that under treatment. Most people that have this are completely asymptomatic. If they are symptomatic, it's usually borderly symptomatic. So most of the time they are found on incidental EKG. A lot of times they're found if they're having like heart attack symptoms. They will end up with a block because it's damaged the tissue where the fibers are. I don't know if you guys can see those or not. So the right bundle branch block, you get the little rabbit ear appearance. So if you look, basically the third row over at the top, I don't know if you can see, but instead of having just one peak, it has like a double peak. I'll give you better pictures in here. This is left. Left one, it's very difficult to determine if they are having an MI because the way that the QRS looks just like when you have an MI. So treatment for this is treat whatever disorder they have, if the one can be found. It may require a pacemaker, especially if syncope has occurred, if they're very symptomatic, if they're short of breath, if they're not perfusing well. And most do not require any treatment other than, monitoring periodically to make sure it hasn't done anything worse, and that their symptoms aren't worsening. Left, this is the one that you can't really tell if they're having like MIs. So, and it's got a higher rate of cardiac disease and mortality. That's it. And I think I have those on there. So, have you guys ever heard of PVCs or premature ventricular contractions? Most of you have probably had one or two in your lifetime. You'll have some during finals. These are very common. So, these are usually little beats by themselves that occur in the ventricles, from tissue in the ventricles. So your heart will just be beating along pretty regular, and then you'll get some kind of abnormal little whoop. Sometimes people can feel these, and they'll tell you that they just feel like their heart just went clunk in their chest, and then started beating again. There's lots of reasons that these occur. Stress hormones in our body can make it, which is why you guys are going to have them during finals. These are, can happen because of your, which I don't see most of you drinking energy drinks, good for you. Coffee, all of that good stuff. So it's just and they're usually premature beats, so you're beating along just normally, and then your heart will just all of a sudden go, oh, we're going to throw this one in. And they can come from different places in the heart. So I have some pictures of some EKGs on here where they have premature contractions from two different areas of the heart on the same EKG. Very common to have no symptoms. This is where they will complain, oh, my heart skipped a beat, or it would clunk, or something felt weird in there for a second. They can become progressive. You can have more than one, and they can come in runs, where you get a whole bunch of them together. There's also something that's called bigeminy, trigeminy, where it comes every other beat or every third beat and is regular. More common as we age. My philosophy on that is just the stuff wears out over time. Alcohol consumption, caffeine, this is where the energy drinks come in. Over-the-counter drugs that contain caffeine, like Excedrin. Cold medicine, pseudoephedrine is a major offender of this. And of course, if anyone's doing crack. Heart failure. So if you are in heart failure and your ventricles are enlarged and your heart's kind of floppy, stuff isn't working right in there anymore. So you'll start getting kind of repair of the tissues, and then you can get some abnormal beats and that sort of thing from that happening, or just stress on the heart itself. And then physical or emotional stress. A lot of times patients will come in and, a family member has died or something traumatic has happened and they're stressing, or even an acute onset of depression, and it's releasing all the stress hormones in the body. They may be having PVCs just from that. Valve disorders can cause it, so people with valve disorders, it can trigger irregular beats. Once again, the electrolyte disorders, so potassium chloride, sodium, they've been throwing up and having diarrhea for a week. That may make conduction a little abnormal, especially potassium. Hyperthyroidism, that just speeds everything up, which is why it's really common in the tachyarrhythmias, and then it can just make irregular beats as well. Diagnosis is usually done with EKG. You can't, obviously, you can feel these sometimes if they're pretty regular. You'll have beats that don't come at a regular interval, but it's not irregular like atrial fibrillation. You'll just once in a while feel something that either feels stronger or comes at the wrong time, and then they'll be normal after that. bigeminy and trigeminy, that's where they come every other beat or every third beat and are kind of regular. Most of these, and this is kind of strange, you'd think this would be backwards. Most of the time, if people have PVCs, they get better or go away when they exercise, because the main pathway of electrical activity takes over. If they don't, or if they get worse, cardiac mortality risk is much greater. And this is what they look like. So you can see the top one, they're actually in bigeminy, the top left one. Every other beat is an irregular looking beat, so you can see how wide it is at the bottom and what it looks like compared to the normal next to it. And then there's just a little single PVC on the second one at the top. And then the bottom one, you can see that there's two of them, but they look different. When they look different like that, that means they're coming from two different areas of the ventricles. So they're having abnormal electrical activity from two different places. So the ones where they're all coming from the same place are called monophasic. Means there is just one source. And then the bottom ones where there's multiple, they're called multifocal. So treatment, you want to rule out the electrolyte disorders, thyroid disorders, anything you can reverse that may be causing it. Most people, if they're healthy, you don't do anything for it unless they become where they're having a lot of them, one right after the other. You can, if they're frequent, they're making them have kind of tachy, or becoming tachycardic with it, you can put them on beta blockers and things like that. There's a big list of drugs in here that you can use for that. There are some of them that are contraindicated, again, once because it can send them into an abnormal rhythm if you're using rhythm drugs. And just like in the atria, if it's nothing's working, they can be ablated. If they'll do electrophysiology studies and then find where they need to zap little areas to keep the beats from coming. That generally doesn't have to happen. Most of the time they're just asymptomatic and go on. And that's it. You guys have any questions about that? You guys need another break before we finish the last three? Okay. Sick sinus syndrome. This one is very odd because you get a lot of, it's also called bradycardic tachycardic syndrome or tachybrady syndrome because they go, like on this EKG, through spots of, you can see there's a huge pause with no beats, and then tachycardia usually shows up. So they go in between, especially if they're having long pauses like the top and the bottom strips, they may have episodes of syncope with that. If it's shorter, like the middle strip there, they may not have very many symptoms at all. This is very hard to treat. It's usually in older people. It can cause like sinus arrest, which is like the big pauses there, where it just stops. You can get sinoatrial exit blocks are sometimes the cause of this. Most of the time, they don't know why it happened unless there's something happened to the heart, like if they've had a heart attack, if there's some ischemia. It does not, so if the person is able, because mind you, this happens in a lot of old people, if you can have them exercise, it does not fix the rate problem, and they'll still have like the sinus arrests and things in there. It doesn't respond like a normal heart would. Usually no symptoms, usually old people. Sometimes they may have SVT in there, so they'll have that and then go completely into a bradycardic rhythm for a little while. They may go into AFib. This is sort of the diagnosis of last resort when they're having all of this crazy stuff that goes on. It can be caused by medications. Of course, you know, most elderly people nowadays are on 1,000 medications at once. So some of those intermingling can be the cause. This is really difficult to find. This is where sometimes the Holter monitors help. You might not capture this on a single EKG in the office, so they may have to be monitored continuously. So there's different kinds of Holter monitors. There's the ones where the people push the button when they're having symptoms, and then they have continuous ones where they just wear them for a shorter period of time. And then this was, I thought, really interesting. You can do the EKG while you're doing a carotid, like sinus massage, like you would for vagal people. And if it causes asystole for a little bit, it's pretty positive that that's what the problem is. Although I'm not sure I'd be doing that in the office either. You want your patient going into asystole while you're rubbing their neck. And usually the diagnosis is made by the ambulatory monitor because they are so hard to find in the clinic. Sometimes the electrophysiology studies, but most people end up with Holter monitor first. And then the symptoms are very bizarre. So they may feel like their heart's racing and then they're not pumping anywhere and they're dizzy and can't breathe because of the bradycardia episodes. So these are the list of medications that can cause the syndrome. We don't know why it goes from, like if they're on a beta blocker, well, why do they go into tachycardia and then just nothing? So they're not really sure why that does that. This is really interesting. I actually have a patient that has sarcoidosis and they do have sick sinus syndrome from it. So, and I stuck the Chagas disease in there. We probably are not going to see that here, although I will tell you, we do have that bug in Oklahoma. And then coronary disease is one of the least common causes of this, where it affects everything else and every other rhythm that we've gone over. It doesn't affect this much. And once again, most people are asymptomatic, or they'll complain that they're having palpitations or fatigue. Treatment, none. If they're asymptomatic, you don't have to do anything. If they are symptomatic, you can remove any of the medications that can cause it first and switch into something else. And if it's really bad, then they get a pacemaker. However, this is a problem with this particular syndrome, so if you're pacing someone, they're usually set between 60 and 70 beats per minute. Well, what happens if they're having a tachy episode? Like this one goes between tachycardic and bradycardic. They can still have the tachy episodes, so they can still have the rates go up. You guys have any questions about that? That was probably the hardest one to diagnose because it comes and goes and it has very bizarre symptoms. We're down to the last two. Okay, VFib will be really fast because if they're in this, you better be doing CPR. So this is where, instead of atrial fibrillation, now you get to ventricular fibrillation. So your ventricles are not pumping pretty well anything. This is cardiac arrest for the most part. And you better hope if it happens to you that somebody's with you that knows how to do CPR. Because it is pretty well fatal if somebody doesn't start doing CPR immediately. So, causes of this, ventricular tachycardia. So that rhythm will often go into ventricular fibrillation if not corrected. So just keep in mind, remember all of the processes. We have those medicines that you're treating your AFib patient with, which is the most common cardiac arrhythmia. And now it's sent them into ventricular tachycardia, and then they go into VFib. So you want to be careful with the rhythm drugs. And then, of course, the acute MI, the acute infarction is usually the cause of this. there's a whole list of other things in there, drowning, heart disease, pneumothorax, any kind of trauma to the chest, so you have somebody that was in a car accident and their airbag went off. Well, they can go into an abnormal rhythm because it punched their chest so hard. If they're losing blood and are hypovolemic. Oh, people that get shocked, this unfortunately I will tell you happens more frequently than you think. So you get some guy that's working on his house and zaps himself because he doesn't know what he's doing, and it can send them into any kind of abnormal rhythm, so they can immediately fall out and go into ventricular fibrillation. It can put them in VTAC and then go into this, so any of that can cause that. And basically this is going to be your person that completely falls out. So this is the one, you know, that basically has a syncopal episode, is completely non-responsive, and for the most, there's no, you can't feel much of a pulse. They may complain of chest pain, dizziness, nausea, shortness of breath, or just bleh, and it's usually just, they're done. CPR, this is what you're going to be doing. So this is ACLS protocols. I put a link in here somewhere for the ACLS protocols since you guys are going to have to do that. Some of the guidelines for that changed and are changing again next year, so maybe. So this really is, you immediately are doing CPR, basically following ACLS guidelines. I'm not going to go into the meds for that. You guys will learn that for ACLS. This is always an emergency, immediate. Even if they're still talking to you, it's an emergency. They need to be basically zapped back into rhythm and given drugs to help with that. You can find out afterward why it happened. So if they're on some of those antiarrhythmic meds and you think maybe that's the cause because they generally don't have any physical heart disease, you might think about changing their meds later. That's not something you will worry about at the time that this is occurring. This is what it looks like. A big squiggly line. Nothing is working. There's no P waves, there's no discernible QRS, it's just a big squiggly line. And that's it.
Is it common to go in and out of like VTAC and VFib, or is there a real way to differentiate between the two when they're both happening at once?
Oh, yeah, so ventricular tachycardia, you still see a viable, like QRS. It may be wide and just like this. This, there's nothing, it's just fibrillation. So, and yes, they can go in and out of that. Generally, if they get to VFib, they're gonna, it's VFib.
Okay.
So, if you generally have to zap them back out of that. Now, VTAC is different. They can go in and out of that rhythm pretty easily from other kinds of, you know, if they have atrial fibrillation and their meds are giving them problems, then they go into VTAC. Well, it may be that for a little while, then go back.
Okay.
And they can go back into a normal rhythm or back into VFib.
But typically, VFib wouldn't go to VTAC. and back.
Not generally. And usually, once you get to VFib, you're doing CPR and they're not coming out of that without some major help. You're hoping they go back into a normal sinus rhythm.
Okay.
But yes, they can go back into, like if you're doing CPR or giving them meds or shocked them, and they can go from VFib to VTAC from that, and it's not impossible that they couldn't come out in and out on its own, but it generally doesn't.
Okay.
And the last one, this one's really easy. So torsades, generally this is something that happens from VFib. So this is what it looks like. And it can happen from VTAC as well. It is a type of ventricular tachycardia, but it's very distinctive. So on the rhythm strip or the EKG, you get this where it looks like it morphs or turns as it's going along, kind of like a ribbon. So you get those great big peaks, and then they'll become small again and it just looks like it twists. They're usually not doing well if this is going on either. This is nearly as bad as AFib. It can happen from hypokalemia, so if their potassium is low, once again, the people that have been throwing up and having diarrhea, if their electrolytes are out of whack, this can happen to them. Hypomagnesium, that one is usually the main cause because the treatment for this is actually IV magnesium sulfate. And any drugs that prolong the QT interval. So, you guys know what I'm talking about when I say that? Okay. So if this widens out, so from Q to T, if this starts widening out, then that can send them into a normal rhythm. There are tons of drugs that cause that. Phenergan, you get it all the time for nausea, causes QT prolongation. Zithromax, Z-Pax, QT prolongation. Cipro, a lot of the antibiotics you think are pretty benign can cause this to occur. Now, does it happen a lot from that? But it can, especially if you put them on multiple drugs that have QT prolongation. So you're giving somebody Phenergan for nausea, and they're taking Cipro and something else already. The combo of that may prolong that, and then you just flip into an abnormal rhythm. So symptoms of this are the same as VTAC. The only different really is the treatment. You're going to find this on an EKG. You're going to do laboratory studies to try to figure out if their electrolytes are out of normal. Echocardiogram, just to make sure that there's not, they're perfusing. Now, if it's emergent and they're not perfusing and they're not coherent, once again, you go into, I'm going to zap them. This is another picture of what they look like. Some of it's not as obvious as others. And treatment, you can use IV beta blockers. Magnesium sulfate is a treatment of choice. That's usually what they always give. And then you can pace them too if they're not perfusing. Sometimes they'll get external pacing before a regular pacer can be implanted. Patients will tell you that is not firm, you better sedate them first. And that's it. You're all done. You guys have any questions about the bazillion things that
I have a picture about slide number 6. So,
number 6?
I only
Which
see-
one was that?
the percent.
Oh,
So on that, I only see like the bottom one has clearly a QT prolonged interval. Like what
are you talking about this one?
Yeah, that very bottom one.
Okay, so you can see all of them are ventricular tachycardia. So you're not, there is no QT. Prolonged QT can cause it, you won't see it on here. So the top one's probably the least discernible for Torsades, so you can see how the waves get like taller and then shorter again, especially the bottom one, and then you can see even the bottom one has some little normal QTs in there. The middle one is probably the best one because it gets taller and then narrow and then tall and narrow, kind of like when you twist a ribbon, is what it looks like. The top one's harder to tell that that's what it is. It's easier to see if the patient's actually hooked up to the cardiac monitor and you can see it as it's going across the screen.
How does that look different than the EFib? You might have already gone into that.
It's really just a matter of it looking like it's twisting. So you get that, the real tall ones and they get short again and then tall and then short. I wish I had I tried to find a live one of these where it could just feed so you could see it going along because it's easier to tell because you can see they get real big and floppy looking and then it'll get narrow again. It's like like the electrical activity is turning. It's harder to see in the still pictures. You can find videos on YouTube of it. And then I brought the toy with me if you guys want to play with this. I brought